In the previous lecture we discussed hypertension pathophysiology. And after talking about how the body raises the blood pressure, we concluded that the drugs that can be used to decrease the blood pressure, or in other words, the drugs that can manage hypertension, either work as sympatholytics, interfere with renin-angiotensin-aldosterone system, diuretics, or calcium channel blockers. And each of these categories is further subdivided to other groups. In this lecture we'll discuss the sympatholytics that can be used to manage hypertension. As we know from the lectures of ANS, sympatholytics could be divided to centrally acting, alpha or beta blockers, both alpha and beta blockers, adrenergic neuron blockers. Note that, all what we'll discuss in this lecture, have been discussed in details in separate lectures before in the ANS chapter. The lecture's PDF will be down in the description, so don't worry about writing down. Let's start. The centrally acting agents such as Clonidine, alpha-methyl Dopa, and the newer generation Clonidine and Iodine. Let's briefly discuss their mechanisms. Clonidine acts by stimulation of central alpha-2 receptors, and that decreases the sympathetic outflow to the periphery, so decreases total peripheral vascular resistance and decreases blood pressure. It is used primarily for the treatment of hypertension that has not responded adequately to treatment with 2 or more drugs. It is particularly useful in the treatment of hypertensive patients with concomitant renal disease, as it does not decrease renal blood flow or glomerular filtration. Its adverse effects include sedation, dry mouth and constipation. Rebound hypertension occurs following abrupt withdrawal of Clonidine, so it should be withdrawn slowly if discontinuation is required. Alpha-methyl Dopa acts by inhibition of Dopa decarboxylase enzyme, which converts Dopa into dopamine. And as we know, dopamine is a precursor for norepinephrine and subsequently epinephrine. This inhibition results in reduced dopaminergic and adrenergic neurotransmission in the peripheral nervous system. It is converted to alpha-methyl norepinephrine by dopamine beta hydroxylase. Alpha-methyl norepinephrine is an agonist of presynaptic alpha-2 adrenergic receptors. Activation of these receptors in the brainstem inhibits sympathetic outflow and lower blood pressure. The most common side effects of methyl Dopa are sedation and drowsiness. It is mainly used for management of hypertension in pregnancy. Clonidine is a selective agonist at the imidazolin receptor subtype 1. This receptor subtype is found in specific areas in the medulla oblongata. It therefore causes a decrease in sympathetic nervous system activity, and therefore a decrease in blood pressure. And the last agent in this category, Iodine, shows greater selectivity for imidazolin receptors than for cerebral alpha-2 receptors. Side effects include dry mouth, sedation, fatigue and dizziness, but they are less pronounced with the newer generation. Now let's move to the beta blockers. Beta blockers are a treatment option for hypertensive patients with concomitant heart disease, such as supraventricular tachyarrhythmia, previous myocardial infarction, angina pectoris, and chronic heart failure. The beta blockers reduce blood pressure primarily by decreasing cardiac output, by blocking beta-1 receptors in the heart. They also block beta-1 receptors in juxtaglomerular cells in kidneys, so inhibit renin release, thus decreasing the formation of angiotensin II and the secretion of aldosterone. They may also decrease the sympathetic outflow from the CNS, by blocking the presynaptic beta receptors. The prototype beta blocker is propranolol, which acts at both beta-1 and beta-2 receptors. Selective blockers of beta-1 receptors, such as metoprolol, atenolol, bisoprolol and acebutolol. Nebivolol is a selective blocker of beta-1 receptors, which also increases the production of nitric oxide, leading to vasodilation. Let's discuss their actions and contraindications in brief, and for more information you can watch the beta blockers lecture in the ANS chapter. The non-selective beta blockers, such as propranolol and nadolol, are contraindicated in hypertensive patients with asthma, due to their blockade of beta-2 receptors in the lungs, causing bronchoconstriction. and the selective beta blockers may be administered cautiously to patients with asthma. Beta blockers should also be used cautiously in the treatment of patients with acute heart failure or peripheral vascular disease, and with diabetic patients, as they potentiate the hypoglycemic activity of insulin and oral hypoglycemic drugs, due to blocking of hepatic beta-2 receptors mediated glycogenolysis. Their adverse effects include bradycardia, hypotension, and CNS side effects such as fatigue, lethargy, and insomnia. They may decrease libido and cause erectile dysfunction. They also may disturb lipid metabolism, decreasing high-density lipoprotein cholesterol, and increasing triglycerides. Abrupt withdrawal may induce angina, myocardial infarction, and even sudden death in patients with ischemic heart disease. So it should be withdrawn slowly over a few weeks. And now let's move to the alpha blockers. Prazosin, doxazosin, and terazosin. They are selective competitive antagonists at alpha-1 receptors in the blood vessels, causing vasodilatation and decreasing blood pressure. Reflex tachycardia and postural hypotension often occur at the onset of treatment, and with dose increases, requiring slow titration of the drug in divided doses. Alpha blockers are no longer recommended as initial treatment for hypertension, but may be used for refractory cases. And there are some agents that block both alpha and beta receptors such as labetalol and carvedilol. Carvedilol is an effective antihypertensive agent, but is mainly used in the treatment of heart failure. Labetalol is used in the management of gestational hypertension and hypertensive emergencies. And the last category we'll talk about today is the adrenergic neuron blockers, and exactly we'll discuss one of them, that is still in use. Rezapine inhibits granular uptake and storage of biogenic amines, such as norepinephrine, dopamine, and serotonin, from the cytoplasm into storage vesicles in the adrenergic nerve terminals in all body tissues. And this causes depletion of biogenic amines. So of course the sympathetic function is impaired, because of decreased release of norepinephrine. It has been used for the management of hypertension, but has largely been replaced with newer agents with better side effect profiles, and fewer drug interactions. That's all for this lecture. If you need more information about these agents, you can get back to their lectures, the links will be down in the description. And if this video was useful for you, leave like and tell us your opinion in a comment. In the next lecture we'll discuss the drugs that interfere with renin-angiotensin system, so subscribe if it's your first time here and keep following us.